Thank you for that kind introduction. I also thank the Governing Council of ISTS and the local organizing committee to give me this opportunity to give this prestigious oration. I hope I do the justice to the oration, especially after Anil. So I'm sure you all agree with that. The last 4 decades, which is my journey as a thyroid surgeon, has made so many revelations and impacted the treatment of the individual thyroid patient. And it's really something which is very, very dynamic and interesting. So 4 decades ago, probably a female presenting in a clinic with a swelling in the neck of 3.5 to 3 centimeter size, bilateral vocal cord mobile with no positive history of or a history of radiation or a family history of cancer, how it would have been treated when there was no standardization of USG reporting, FNAC was infrequently done, surgical guidelines were not there. Probably she would have gone through a surgery with or without neck dissection and RAI for sure. But we have evolved in this, and the Kocher standardized the safe thyroid surgery as already elucidated in 19th century. For decades, what is hurting is for decades we had a thyroidectomy to confirm the diagnosis of malignancy. But ultrasonography and FNAC emerged, and it helped us today. We can, with upward of 90%, we can say that you are dealing with a cancer with these 2 modalities. The recent decade has seen reducing the overtreatment for small, low-risk cancers and also observation of these cancers. And on the other hand, the advances in the molecular diagnostics have enabled highly sensitive diagnostic panels to recognize or to rule out malignancy, but more so in anaplastic and medullary carcinomas, it has really helped us. And identifying the genetic landscape for these cancers. So, something which has not changed, which I want to reiterate for the junior in the auditorium, is that history taking and clinical examination still persist and still should be done with a sincerity. Age and sex are the 2 prognostic factors. And of course, the red signal or red sign or flex signs are extremes of age, rapid increase in size, pain, compressive symptoms, and a local invasion to larynx and esophagus with and vocal cord palsy. A normal voice of the patient does not guarantee has a functioning cord, and every patient should have a 70-degree Hopkins to establish that the patient has a cord palsy. It is for your good and also for a medical legal purpose. So the sonography of the 79, 90, 80 was first generation of sonography machines. We evolved there also, and in 2004 we have a sonography machines which can give us the characterization of the nodule in terms of composition, echogenicity, shape, margin, and the calcification, which helped us to triage this nodule into 5 categories, and thyroids 1 to thyroid 5. Again, 4 and 5 are highly suspicious of cancer, while 1 and 2 are benign. The 3 is equivocal, as it is also in Bethesda. So there was this helped us in a better communication between clinicians and clinician and the patient. Also better characterization of between the benign and the malignant. And it also helped us which nodule needs further investigations. And the most important role it has played is the follow-up of our thyroid cancer patients. This is one area where a simple sonography helps us to see whether the patient has recurred in the node or at primary, and also it has helped us in the latest observational active surveillance with a sonography. So we have really come up a long way, and it has helped us. The CT came later, doesn't require to be done in every patient, but when you are suspecting airway displacement, retrosternality, about the retrosternality, CT is done in a horizontal position, so you might get retrosternal on a reporting, but you always use your clinical acumen of insinuating your fingers in your patient's lower border of the thyroid by giving a little extension and see that it is not true retrosternal or it is just because the patient is in lying down. This will help you to plan your surgery and not have surprises. It also helped us to see the invasion in the larynx, esophagus nodes About the nodes, the central compartment nodes are better delineated by CT because the presence of thyroid gland in the position does not give you a very accurate diagnosis on a sonography. So it should be always complemented when you are wanting to know whether the central compartment nodes are positive or not. There is a publication on the same. The MRI is not done very routinely, but when you want to see the visceral involvement in patients of dysphagia with thyroid cancer or a vascular involvement, MRI helps. MRI also helps as a troubleshooting imaging technique to really confirm if the recurrent lesion nerve is involved or not. If it is involved on CT, MRI helps, and because the sensitivity of MRI is about 94%. The PET came later, and it has really revolutionized the way we can diagnose the redifferentiated cancer. It is not a routine test to be done in a differentiated cancer as a first line. However, when you are suspecting dedifferentiation, it is the choice of investigation, as Dr. Bal also highlighted. And because this happens because the avidity of radioactive iodine decreases as the dedifferentiation happens, and because the cellular division, the PET avidity increases, FDG PET. And it has great value in TENS, which is the thyroglobulin is elevated and scans are negative. So if you do a PET scan, you can localize the disease and treat appropriately. So it has really helped us in dedifferentiated and cancers. The fine needle aspiration biopsy was first done in Sloan Kettering in 1930, never became popular. The Scandinavian group established its diagnostic accuracy, diagnostic value, and it is the North Americans which popularized this technique in 70s and 80s. And I'm very happy to say that the first publication from India on fine needle aspiration was from the Nair Hospital, where I spent 24 years, and I started my journey in Nair in 82. So I'm really proud that I was responsible to contribute to this paper, though I did not get the credit because I was the junior most 32-year-old. So you never get a credit in the publication. The Bethesda again was categorized into 6 categories. The level 5 and 6 is always suspected of cancer, and total thyroidectomy is indicated. First 2 categories are benign, but it is the intermediate which is always doubtful, where there is a risk of cancer, but thyroidectomy will be overkill. Anil elucidated this in so much detail, so it has made my journey or my life easy. There is 3 options: follow-up, repeat FNA after some time, and genetic testing. The follow-up is the ideal way, but the patient sometimes may be worried or may not be happy with the word cancer or possibility of cancer, but we have to counsel your patients and then do the repeat FNA, maybe USD guided FNA, and follow up this patient. However, there is a possibility of genetic testing, and these are the diagnostic panels, and these are prognostic panels, the BRAF and TERT, which has therapeutic options in locally advanced, but diagnostic panels are for diagnosing or ruling in or ruling out the cancer. So there are 2 tests. I'll just go through this very quickly so that you get a glimpse of the molecular tests. It's a rule-in test and rule-out test. So that rule-in test rules in the cancer. So the positive predictive value of this test is very high, and you rule in the cancer. While the rule-out test, which is a Afirma gene expression classifier, where you rule out the cancer because the negative predictive value is very high, and you rule out the cancer. So these are very expensive tests. I'll come upon to that. The ideal test is that the negative and the positive predictive value should be 100%, so that you don't need to do a hemithyroidectomy. So as Anil is saying, that it is already established internationally, especially Europe and America, that the sensitivity and is high, but it obviates, it removes the need for the thyroidectomy in 61% of Bethesda 3 and 4 categories. So probably that makes it very interesting that if you can avoid thyroidectomy, you advise this test, and if the test is positive or negative, you take your decision whether to do a thyroid or not. So the cost-effective analysis of this test done in America is it's cheaper to do the test, and the insurance companies were smart. They allowed this test in the insurance policies, because the diagnostic lobectomy cost $38,000, while this test cost $17,000. So they save money. If the test is negative, you don't require a thyroidectomy. So probably it became popular for many commercial reasons also. In India, this test costs 3 lakhs rupees. But however, I must make you aware that these tests are now locally devised by many companies like Datar and MedGenome. It costs about 20,000 rupees, available easily. They organize everything to collect the sample from your center and give you the report. So you must be aware that these tests are available at a cheaper rate of 20,000 rupees in India, Bangalore-based company called MedGenome, and Datar in Bombay. You can choose whatever, but it is available today, and we can offer, if the patient is insistent or he has researched the Google too much and it's up your head, then probably you can definitely advise this test. But what I want to say is, Anil mentioned that triage your nodules very well. And here I have an Indian Jugaad, an impact study done by Neeti and Abhishek. Neeti and Abhishek are pioneering this work. What they have done is the clinical examination, imaging, and cytopathology individually gives us some clue how much is the rate of malignancy in a particular nodule. But when you integrate all the three together, it gives you an integrated score, and then you do the likelihood ratio. There is a little calculation. I cannot go into the detail in half an hour. There's a likelihood ratio is calculated, and then your pre-test probability, integrated score, and likelihood ratio are charted on a nomogram, and then you get the post-test probability. Now, in this particular case, the post-test probability was 97%. That means this patient had a chart like this, and believe me, the patient turned out to be follicular variant of papillary carcinoma. What I want to say is that they have done about 600 patients. It was, the study is over, the results are out, very promising results. Again, something simple as clinical examination, sonography, and your FNAC results, little calculation, little charting, but you get a probability of cancer so that you can take your decision to do the extent of surgery as well as node addressing the nodes, or not to do the surgery. In their study, 60% were benign, 40% were malignant. They are already writing the manuscript, and the publication will be out in a very good journal. Please look for this paper if you really want to have a simple method to diagnose thyroid cancer from your clinical examination and simple investigation findings. The rationale of the evolution of surgery was based basically on the biology, and Anil again mentioned the biology is king. So majority of these cancers are the well-differentiated cancer, leads to anaplastic when the de-differentiation happens, and also when the genomic instability, when the size increases, extrathyroid extension, distant metastasis, and mortality is also there. But luckily for us, this is a very small group of patients which leads to anaplastic or undifferentiated. Majority, 80-85% of patients have a well-differentiated, and they have a good prognosis if treated well in the first go, addressing everything, the primary as well as the node if required, and if there is RAI requirement. So this is a well-behaved cancer, and this should be on the back of your mind always, that we have to be precise, we have to be complete in the first go. Lot of changes and practices in philosophy happen over a period of time after this, and they are in terms of risk stratification of the thyroid cancer, the DTC and epidemic, which already highlighted. Less is more, leaning more towards more balanced, less aggressive management philosophy, shift towards hemithyroidectomy, lesser central compartment dissections, and active surveillance strategies for low-risk cancers. And again, for RAI, risk stratification based administration of RAI, and not all patient needs RAI. So it is an extremely evolving field. So this MSKCC low risk risk stratification criteria, which is based on the patient and the tumor factors, they divided this into 3 categories: low, intermediate, high. and the intermediate grade, they divided into low intermediate and high grade intermediate, which ATA has. If you see the ATA guidelines now, ATA has incorporated this classification of the risk stratification, and they have given exactly low intermediate and high intermediate. And the low grade has a HAMI, intermediate towards low is HAMI, and intermediate towards and high grade will go towards total. They told this long back with a proof that 99% of the low risk cancer patients survives at 20 years. So this was the basis of doing less for HAMI. The ATA guidelines, risk stratification for ATA is after the surgery, after you get the histopathology report, you stratify again these nodules into high risk, intermediate and low risk, and then treat accordingly, which is also a very established thing. The ATA 25 has done the same thing, but as I mentioned, they have incorporated intermediate group into low intermediate and high intermediate, which I was talking about. And also they have separately given for oncocytic carcinoma and follicular variant of papillary carcinoma. I cannot go into the detail of this. The dynamic risk stratification also helps us at 1 year of the treatment that you stratify your group patients into excellent, intermediate, biochemically incomplete, and structurally incomplete. So if the patient was high risk to start with, after treatment he has an excellent response, then he is no more categorized as a high risk, and he falls into the excellent response group, where he is followed up every 1 or 2 years, and the TSH goal is about 0.5 to 2. I will not go into the detail of everything, but the structurally incomplete group is the one which requires you to be more vigilant and plan your treatment and follow-ups and everything very aggressively. The ATA risk stratification also says the same thing in dynamic. Again, the intermediate group is divided into high, intermediate and low, which is incorporated in this figure. Something new, which is data framework. DATA stands for diagnose, assess, treat and assess. This is the latest 25 guidelines. This module is also followed up for the recurrent and the persistent disease. I will not go into the detail of this for the interest of time. The DTC epidemic is basically happened in last 3 to 4 decades with the increasing incidence of cancer in female, male and overall. However, the mortality remained the same. So is this a real epidemic? And without any new risk factors or increased exposure to the known factors? And I think it is not, because it happened because of the alarming rise of the imaging which we do for other conditions. And also some of the country has opportunistic screening program like Korea, where they are picking up these tumors in a large numbers. The lesson learned from DTC is basically active surveillance strategy led to this because of this epidemic. And also it has indirectly contributed to the remote access thyroid surgery. So again, less is more. Anil highlighted this very beautifully, that the squabble for hemithyroidectomy for low risk cancer went on and on and on. We had debates in every conference. This conference, there is no debate. There are papers in favoring HAMI, there are papers in favoring total, and and this situation became worse with 2009 guidelines with bilimuria paper, where it was said that the ATA said that the tumor up to more than 1 centimeter should have a total thyroidectomy and central compartment lymph nodes. And it really led to a lot of complication and unnecessary central compartment dissections. However, 2015 guidelines of ATA with the Adams et al. Paper, somehow we went back to HAMI for low risk up to 4 centimeter. And again, that is to be taken with little bit of a pinch, but at least total thyroidectomy is awarded in this group of patients. This was less is more was analyzed by Brian Kim from Chicago, an endocrinologist, and he also came to a conclusion that 1 to 4 centimeter DTC can safely have a hemithyroidectomies. The 2025 guidelines validates this, which is also highlighted recent by this thing, but conditional recommendations. So they are very smart. They are not still 100% telling us that yes, HAMI can be done. It's a conditional recommendation, so it should be taken with a pinch of salt. Something major happened is in the 8th edition of the AJCC TNM classification, which I think was a very good thing to happen. The age cutoff went on from 45 to 55. The minimal extrathyroidal extension, which was upstaging the disease, is removed from the reporting system. The N1 disease no longer upstage a patient to stage 3, again downstaging the disease. Or T3A and T3B, a new category of tumors depend on the size of the tumor, was established. The level 7 lymph node, which was considered to be the lateral compartment lymph node, is reclassified as a central compartment lymph node as N1A. And I think all this led to something which is downstaging the disease and less treatment. So you can imagine how we have evolved over a period of time. Same thing for prophylactic neck dissection. The low-risk cancers does not require a prophylactic dissection if they are intrathyroidal, node negative, and also follicular cancers, while T3 and T4 cancers with an involved lateral neck compartment neck dissection should be offered a prophylactic neck dissection. Same thing was accepted by British guidelines and AHNS guidelines. We evolved in a surgical technique, and in 1992, with this Delbridge and Reeve paper, who highlighted the capsular dissection, ligating which involves hugging the thyroid gland, working away from the TO groove, ligating the terminal branches of superior and the inferior thyroid arteries on the gland, so beautifully demonstrated by Niti today in her video today, thus limiting the damage to the recurrent nerve and parathyroid with their blood supply intact. This led to the birth of parathyroid respect, I would say. People started respecting parathyroids, preserving their blood supply, and now we have less and less morbidity. Such a beautiful thing to happen from 92 onwards. I myself have ligated the inferior thyroid artery in 82s and 85s and retracted it, thinking that the nerve passes between, it was a technique for everyone because the nerve passes between the two branches of the inferior thyroid artery, and once you ligate it and lift it, the nerve is preserved. But it has really changed, and I'm so happy. This is a real life picture. You can see the vessels being ligated on the thyroid gland, and the recurrent langer nerve with her intact fascia is demonstrated in the picture. So this is the technique today and should be followed by each and everyone. The surgical adjunct came later. I mean, the harmonic and ligature are there for some time. Nerve monitoring, parathyroid autofluorescence, the robots, everything has really helped the surgeon, but one has to weigh the use. One thing I would like to say about the recurrent langer nerve monitoring is, it was said by Prolio in 33 that some RLN seen is RLN injured. And we moved to Wheeler making a comment in 1999 that it is fundamental surgical principle to avoid damaging a nerve, and something which you want to preserve should be seen very carefully and preserved. Today in 25 or maybe little 20s, that we say that nerve preserved is not necessarily now functioning, and you require a monitoring for this, and it has come a long way. We saw a beautiful demonstration of it yesterday in a live surgery on all the 4 cases. This technology has really helped reducing the vocal transient and the permanent vocal cord palsy with an accuracy of high sensitivity of up to 99%. So, and it is a dynamically, the machines are also upgraded, and it is really something which I want the younger surgeons sitting in the auditorium to take up this. We have an amazing paper led by Prathmesh and all the stalwarts. It's an Indian publication published 1 month ago in a PubMed journal. And I would urge those who want to start their journey and already started the journey to read this publication very carefully and get more motivated to do this. Another word is that data saving. Please save your data so that we can analyze these data one day and show to the world what is the Indian situation of this technology. I will not go into the detail of this. However, I'll reiterate one thing, that the total thyroidectomy with a nodal basin clearance if required, not total thyroid, appropriate thyroidectomy with nodal basin clearance at the first time is the best treatment you can offer to your patient, whichever approach you do. It is not the approach which decides, it's the completeness of the surgery with the node dissection if required, which will decide the future of the patient. There are complications of each technique. It has a long learning curve. It has cost issues, and it has accessibility issues. Robot is not everywhere. So be careful, don't get excited, learn all these robotic surgeries and take your call whether you are enough mastered your open techniques and then venture onto this. I'm sure you are all tech savvy, young generation of surgeon, you are very good at technology, and one day maybe down the road in 10 years we will have some data. Coming to the RAI ablation, we have fantastic 2 papers, Estamibel 1 and trials as Estamibel 2, which told us that low risk thyroid cancers does not require a radioactive ablation, and if at all the dose required is 30 millicuries. So it is really revolutionized the way the RAI is being given, because I have seen that every patient who turns out to be cancer was referred for RAI to RMC Center, Tata. I'm talking of 80s and early 90s, but no more. Now we have a clear-cut guidelines, and ION trial, which is a British trial, 33 centers, 504 patients across UK, just released 2 months ago, says that the 5-year recurrence-free survival is about 98% in no ablation group, as against 96.3% in ablation group. So the jury is out, no radioactive iodine for low-risk cancers, and if at all it is to be given in intermediate group, the dose is 30 millicuries. The 8825 also says the same thing, no ablation for low risk, but intermediate risk, the dose which was 2015 guidelines was 150 millicurie, which is reduced to 100 millicurie, and a high risk patients, the dose was 200 millicurie, which is reduced to 150 millicurie. Again, you can see that less is more. We are really going towards less with the evidence, of course. It is not individual madness of a person. Active surveillance for low risk cancer is here to stay. This Miyauchi paper, 1235 patients, 10-year observation, only 8% showed increase in size and 3.8% showed nodal metastasis. Anil's graph was very nice. He cited 3 and showed nodal primary and, with the graphical manner, so it shows the same thing. We have but patient, we are proud to present that the Indian Society of Thyroid Surgeons, we have our own guidelines published in 2024 January, released through the hands of Dr. Jatin Shah and completely reviewed by him. I urge those of you who have not read this or downloaded this, it's a free download, to download this. All eyes are on the targeted therapy, and this lenvatinib and sorafenib by the SELECT and the DECISION trial has really established the role of this in a dedifferentiated cancer. These slides are lent by Abhishek, who has a very good series, and he's going to present his work also. These patients had an extension to larynx, trachea, esophagus, and skin with a possible R2 resection. The lenvatinib was given, and this is the result after 2 months. It has offered whether to continue the therapy for a little longer and then operate, but it has really you wouldn't have operated this patient which is at the baseline. So it has really changed the way we have to do this, and as Anil highlighted so beautifully, that if you have a vocal cord palsy, there is no harm giving this in a dedifferentiated cancer, no harm giving this for a while and see whether the functions recover. So I think this is really going to change the way we treat the dedifferentiated cancer. And you can see that the current approach to the thyroid nodule is highly tailored. Throughout, the surgeon must balance the cure with morbidity of this operation and apply evolving evidences to each patient scenario. The field has never been so dynamic. Let's commit to being precise, patient-centric, and science-driven. The future is very exciting with artificial intelligence coming to the machine. Liquid biopsies will replace the invasive biopsies with a simple blood test. Robots are here to stay. Molecular targets will be devised more and more probably, and precision monitoring by better risk models, which will integrate the genomics, imaging, and patient factors to customize the follow-up intensity. I think this is one field which has really, really progressed beautifully, and as I mentioned, the philosophy is less is more. Thank you very much for your patient listening. I invite you to become the member of this society, which is really doing a fantastic job. In 6 years, we have really progressed. We have really expanded our horizons to the APTS, World Congress, and also at NCCN guidelines. We have our own guidelines in these 6 years. It's really a happening association, and I urge each and every thyroid surgeon to become a member of this society. Thank you very much.